Welcome, esteemed colleagues. In this explainer, we will conduct a comprehensive, evidence-based review of Clostridioides difficile infection.
Okay, let's dive into this. We'll start with the fundamental microbiology, move through diagnosis and clinical application, touch on public health imperatives, and then wrap things up with a quick Q&A to solidify the key points.
So we'll begin right at the source, establishing the fundamental characteristics of C. difficile and, of course, the disease it causes. Fundamentally, it's absolutely crucial to remember that not all C. diff is created equal. The organism itself can be a harmless commensal. The real issue, the pathogenicity, is mediated entirely by the toxin-producing strains. It's the expression of toxins A and B that drives the intestinal inflammation we see clinically.
The pathophysiology follows a very clear, almost textbook sequence. It's all initiated by a disruption, an insult to the gut microbiota, that creates an ecologic vacuum. This allows these incredibly resilient spores to survive the stomach acid, germinate in the colon, and then the vegetative cells proliferate, pumping out the toxins that do the real damage.
As you can see, the risk factors are multifactorial. But antibiotic-induced dysbiosis really is the principal predisposing event, and that window of vulnerability can last for 3 months or even longer. You layer on top of that things like advanced age, hospitalization, or even PPI use, and you've got a perfect storm.
Okay, so this naturally leads us to the critical step of accurate diagnosis. How do we differentiate simple carriage from active toxin-mediated disease?
And this is a really important distinction. Detecting the organism is not the same as diagnosing the disease. Asymptomatic carriage is surprisingly common, especially in infants. Our focus, for both diagnosis and treatment, has to be on patients who have clinical symptoms, namely diarrhea, and in whom we can detect the actual toxins. That's why we only test unformed stool.
This really illustrates the diagnostic trade-offs we constantly face. You have a highly sensitive PCR or NAAT that detects the toxin genes, but it can't tell you if they're being expressed. Then you have a toxin EIA that detects the preformed toxins, but has lower sensitivity. It's a classic speed and sensitivity versus clinical specificity debate, which is why many institutions now favor a two-step algorithm to get the best of both worlds.
All right, on the topic of susceptibility, it's actually quite reassuring that resistance to our first-line agents like vancomycin and fidaxomicin remains rare. But, we absolutely must remain vigilant with our surveillance. So, once we've established that diagnosis, we turn to the bedside. Let's discuss the current evidence-based therapeutic interventions. Right. So the crucial point here is that our treatment approach is stratified by severity and setting. Oral vancomycin remains the cornerstone for most hospitalized patients with non-severe CDI. For severe cases or those at high risk for recurrence, fidaxomicin really comes to the forefront. And for children, the principles are similar, just with weight-based dosing and more careful consideration around metronidazole.
It is absolutely imperative to remember this contraindication. Suppressing gut motility might seem like a good idea, but it can have truly catastrophic consequences in active CDI. You risk trapping the toxins and precipitating a toxic megacolon. It's a major do not do.
Now for the thorny challenge of recurrence. Our armamentarium has expanded significantly. We've moved beyond just antibiotics. We now have immunotherapies like bezlotoxumab, a monoclonal antibody that targets toxin B. And of course, there's microbiome restoration via fecal microbiota transplantation, or FMT, which has proven superior for preventing further relapses. All right, let's broaden our focus now. We'll move from the individual patient to the community and institutional level with infection control. This is a non-negotiable principle, a hill to die on in CDI prevention. Alcohol-based sanitizers simply do not kill the spores. It's the mechanical action of washing with good old soap and water that is essential for physically removing them. This specific time frame is a key operational benchmark. We need to know when it's safe to de-escalate isolation precautions. The standard is a minimum of 48 hours symptom-free.
This, combined with mandatory reporting of cases, is how we manage things at the population level.
Even with successful treatment of the initial episode, CDI can have this long tail of complications, and of course, that high risk of recurrence. And this really illustrates the significant challenge of recurrence. We're talking about at least 1 in 5 patients being affected after their initial episode. Most of this is driven by relapse, the regermination of dormant spores that survived the first round of therapy. This comparison starkly highlights the increased danger posed by certain strains. Hypervirulent strains, like the notorious ribotype 027, are associated with a significantly higher mortality rate. It's a potent reminder of why strain typing is so important in outbreak investigation. Okay, let's conclude by just quickly testing our understanding of some of the critical concepts we've discussed. First up, a question on the absolute cornerstone of our entire management pathway, diagnosis. The correct answer here is B. The crucial point, the take-home message, is this: toxin detection is paramount. A positive PCR or culture is just not enough. It may only indicate asymptomatic carriage. Toxin detection is what confirms the pathophysiological activity that's actually causing the disease. All right, next, let's think about a question that bridges patient treatment with public health. The answer has to be C. Discontinuing the inciting agent whenever clinically feasible is the single most fundamental intervention. It directly addresses the root cause by removing the selective pressure, which helps the patient recover and reduces the bacterial load for transmission. And finally, a question on one of the most frustrating and persistent challenges in CDI management. The correct answer is B. This really gets to the heart of the problem. While reinfection can happen, most recurrences are actually relapses. It's the original infection spores surviving antibiotic therapy and then germinating once treatment ends. This is exactly why therapies focused on restoring the microbiome's resistance, like FMT, are so effective. And this leaves us with a final thought to ponder. As we get better and better at treating the patient in front of us, what's the next frontier? How do we finally overcome the incredible environmental resilience of the C. difficile spore to break the cycle of transmission entirely? That is the billion-dollar question.